The rationale is that, as you know, contrast-induced acute kidney injury is a common complication of our procedure. So in order to prevent this complication, hydration is the most important strategy. But we need to tailor our hydration volume according to the patient characteristics. And we have now two most important hydration tailoring. One is left ventricular end-diastolic pressure guided hydration according to the POSEIDON trial. And the other is the urine flow rate guided hydration according to the previous study we did, the REMEDIAL II trial. So these are these different two strategies that we would like to test, and this is why we designed the REMEDIAL III trial. This is a randomized, multi-center, investigator-sponsored, initiated study comparing these two strategies, left ventricular end-diastolic pressure guided hydration versus urine flow rate guided hydration in high-risk patients for contrast-induced acute kidney injury. The first group, LVEDP group, we perform hydration according to the left ventricular end-diastolic pressure. So we assess the pressure at the beginning of the procedure with the PICC catheter. If it's normal, we gave normal saline at the infusion rate is 5 ml per kilo per hour. If the pressure is between 13 and 18 mmHg, the volume is 3 ml per kilo per hour. And if the pressure is more than 18, we goes down to 1.5 ml per kilo per hour. And this hydration continued during the procedure and for 4 hours after the procedure. In the other group, urine flow rate guided group, we utilize the renal guard system, which is a device which allows us to give a perfect matching between infusion and urine flow rate. So if urine flow rate is very high, we will have the same volume infusion or normal sign in the patients. So we need a Foley catheter with this system, and we have a special monitoring on the urine flow rate. So with this system, we gave a priming volume of 250 ml of normal saline in 30 minutes. After that, we inject some furosemide in order to increase the urine flow rate up to 300 ml per hour, and then we can perform the procedure. This balance between the urine flow rate and infusion continued during the treatment, during the procedure, and for 4 hours after the procedure. So these are the two hydration regimen that we compared in our study. So we enrolled 351 patients per group. The patients had a GFR value between 36, so it's a very high-risk patient population. Left ventricular end-diastolic pressure was high, more than 13 in the majority of the patients, more than 50% of the case. And what do we found? We found that the primary endpoint, which was the composite endpoint of contrast-induced AKI and pulmonary edema, occurred in 5.7% of the patients in the urine flow rate guided group and 10.3% in LVEDP guided group. The difference was statistically significant. The relative risk was 0.56. So the number needed to treat to prevent one event with the renal guard therapy was 22. And looking to the different endpoint, contrast-induced AKI occurred in 5% versus 10%, so half in rate in the urine flow rate guided group, and pulmonary edema, one case only in the urine flow rate guided group versus 7 in the LVEDP guided group. The difference was not statistically significant, but there was a strong trend in favor of the urine flow rate guided groups. So also we need to consider the risk of having Foley catheter because the renal guard therapy required a Foley catheter. We had only 3 patients who had complication to this Foley catheter. 1 patient had hematuria and 2 patients had pain during micturition. No case of inflammation infection. Also, we collected the value of potassium. Hypokalemia occurred more often in urine fluoride guided group versus LVEDP, 6% versus 2%. So this is another important aspect we need to consider when we go ahead with the renal GAR therapy. So the concept of the POSEIDON trial is very interesting. This is probably one of the most important studies assessing the role of dosing the hydration volume. Left ventricular end-diastolic pressure is a good parameter, but probably what we need to consider that this value is not a fixed value. Maybe that during the procedure or after, this may change, especially if we are in the grade zone between normal and high. So this is why I think that this tailored hydration should be improved by monitoring the LVEDP before and during the procedure in order to prevent the risk of pulmonary edema, because it's still there. If we had 2% event rate pulmonary edema, and the POSEIDON trial, they had 1.5%. So this is still a problem when we would like to hydrate the patients in the right way. So in my personal view, this study suggests that in patients at high risk of contrast-induced acute kidney injury, the urine fluoride guided hydration should be preferred to left ventricular end-diastolic pressure guided hydration in order to prevent both acute kidney injury and also pulmonary edema. So if we will have today or tomorrow a patient with chronic kidney disease, that is a glomerular filtration rate less than or equal to 45 ml per kilo per minute, and or high risk because of comorbidities like diabetes mellitus, old age, anemia, etc. In these patients, I suggest to utilize a renal GAR system, have a hydration regime according to urine flow rate rather than LVEDP-guided hydration.